So we're going to dim the lights and I'm going to show lots of pictures. This is where I work. I work at North Shore Hospital, and over the years we've had, so I'll just get the laser going. Oops, no, sorry. And over the years we've had some extensions, and most recently we've had the it's working. The elective surgical centre built, and we've had a sky bridge connecting the two. What is breast cancer recurrence? Simply when breast cancer comes back or recurs after initial treatment. Where can it occur? It can occur on the same side, or we call ipsilateral, on the other side, contralateral. It can occur in the breast itself, or in the case of a mastectomy, in the chest wall or the mastectomy scar. It can recur regionally in the lymph nodes, in the axilla, under the clavicle, above the clavicle, or in the internal mammary chain, which is beside the sternum. Recurrence can also be distant, or what we call metastases, and occur in the liver, lung, bone, or elsewhere. The chances of recurrence or being local or regional can be anything up to 27%, and of those, 9 to 25% can be distant, and there's also a risk of contralateral recurrence of about 5 to 10%. When does it occur? Well, most will occur in the first 5 years, the peak being at about year 2, but there's still a risk from years 5 to 20, and you can still get cancer recurrence after 20 years. So how do we monitor for recurrence? Well, mammography is the only imaging modality that's commonly recommended for breast cancer surveillance. Now, we don't have randomized control studies, but the recommendation is from the major worldwide oncology groups throughout the world. Now, we know that screening mammography for women with an average risk of breast cancer results in a 20 to 30% reduction in breast cancer mortality. And women with an elevated risk for breast cancer, including those who have already been treated for breast cancer, will also benefit from screening mammography. We've got data from New Zealand, and the Ministry of Health have recently published a paper regarding the mortality benefits of breast screening. They analysed the women who've been screened from 1999 to 2011 and divided them into two groups, those who were screened and those who weren't screened, and found out those who died from breast cancer and those who didn't. And this is a summary of the results. In the ever-screened group, there were 3.7 million women, and in the never-screened group, 5.5 million, or 5.4 million. Person years is the number of years each woman has been screened, of which there was 18 million in the ever-screened and 26 million in the never-screened. There were 873 breast cancers in the ever-screened and 3,500 in the never-screened, and this works out to be a breast cancer mortality of 23.5 per 100,000 in the screened and 65 per 100,000 in the never screened. So that shows a 64% reduction in mortality between the ever screened and never screened group. But you've got to adjust for certain biases such as age and ethnicity and selection. So the estimated mortality of the ever screened group at the average participation rate was 29%. Oops, sorry. However, the participation rate has increased over time, and so the ever screened group mortality reduction increases to 34%. And the good news is for those who are screened regularly, who have had 3 or more mammograms, the mortality reduction benefit is 39%. There were also some prognostic indicators of improved survival which came out of the study, and I'll just go through this. In the Everscreen group, there were more low-grade or cancers compared to the Neverscreen group, and fewer high-grade or the faster-growing cancers. There was more localized disease and less distant disease. There were fewer women who had more than one cancer, and the cancer's sizes were smaller. So what should we do? We will do a mammogram of the contralateral breast in patients with a mastectomy, and we'll do both breasts in women who've had breast conserving surgery. We would recommend annual mammograms, but wait at least 6 months after radiotherapy, and do that for 5 years after treatment, and thereafter every 1 to 2 years. We can pick up breast cancer recurrences in the ipsilateral breast in 50 to 80%, and pick up more cancers in the contralateral breast. The difference being the patients with surgery, there is scarring which may obscure cancer recurrence. I'll just explain some terms because I'm going to show a few cases. Cranial is towards the head, caudal is towards the tail, superior is above and inferior is below, medial is towards the middle, and lateral is towards the outside, and position of a lesion in the breast is denoted by the clock face, 12 being superior, 6 being inferior, and 9 and 3 are lateral and medial on the right, and medial and lateral on the left. The standard views that we take are the mediolateral oblique, which is along the line of the pectoralis, and we generate this image, and you can see just on the very edge of the mammogram that we've included the pectoralis muscle. The other view is the craniocaudal view that's done horizontally, and we generate this image, but we then rotate the image 90 degrees so that we can compare it with the other side. So in this case, we've got the two mediolateral oblique views. The breasts, the darker areas is the fat, the whiter areas is the fibrous and glandular tissue, and you can see on the right-hand side, which is actually your left, because that's the way we view the images, there is an asymmetric white area. And on the craniocaudal view, and this is how we view it, we put them side by side, and at the top of the screen is the lateral aspect of the breast, and at the bottom of the screen is the medial aspect. Again, you can see a white area on the right lateral breast. So when we do spot views, we can see the margins of this better, and you can see what we call they're spiculated. So they've got the little sharp edges. On ultrasound, this is what it looks like. Just explain the anatomy. At the very top, towards the top of the screen is the skin. The fat looks a little bit darker. The fibrous tissue and glandular tissue is a little bit whiter, and towards the bottom of the screen is the darker muscle. The round dark area in the centre is the mass, and we can see that from the margins it's quite fuzzy and corresponds to the spiculations that we see on the mammogram. And that lesion was biopsied, and that showed up to be an infiltrating ductal carcinoma. In this second case, it's hard to see an abnormality, but in fact there is an asymmetric density on the left as marked by the red arrow. On the other view, again, it's maybe quite hard to see, but there is a corresponding asymmetric density, again marked by the red arrow, and we did additional views, and it persisted. So it's not just a little bit of fibrous or glandular tissue which is overlapping. There is a lesion there. But for something so small, we didn't see that on ultrasound, so she had a stereotactic guided biopsy. And this is where we do two views at different angles, and the machine works out where to put the needle in the X, Y, and Z coordinates to take a sample, and that was an infiltrating ductal carcinoma. Mammography does have some limitations. It can be painful for some women. The overall sensitivity in detecting cancers is about 85%, but it's not equally effective in all women. In women with dense breasts, the sensitivity is reduced and can go down to less than half. And women with extremely dense breasts have an increased risk of developing breast cancer compared to those with completely fatty breasts. And cancers detected in women with dense breasts are generally larger and more frequently node positive. So let me explain breast density. On the far left, the breast consists of mainly fatty tissue, and fatty tissue is dark, so we would classify that as almost entirely fatty. The second image, there are some white areas consisting of fibrous and glandular tissue, so that's where we classify that as scattered areas of fibroglandular density. The third image, there is a little bit more white, and we would classify that as heterogeneously dense, which may obscure with small lesions. And the last image is a lot of dense white tissue. There is some fat in between, but it is actually extremely dense, and it does decrease the sensitivity for detecting cancers. In the latter two images, in women with heterogeneously dense or extremely dense breasts, there is anything from 2 to 6 times increase in the risk of breast cancer compared to a woman with almost entirely fatty breasts. Half of women between 40 to 49 years, and almost a third of women from 70 to 79 years will have dense breasts. So there's a debate going on as to what we can do about that, because it's difficult to detect cancers in dense breasts. And larger tumours can occur in dense breasts. And in fact, in the United States, 19 states in the USA have a law which says that the radiologist must inform the patient who has dense breasts that they may benefit from additional screening studies. Of this, breast ultrasound can be used, but it can also detect many benign masses. Breast MRI is not affected by breast density, but at the moment breast MRI is used specifically for high-risk patients. It does involve a long time in the procedure. It does involve intravenous contrast and is expensive. A new technology has recently become available, digital breast tomosynthesis, because in conventional mammography, the superimposed tissue can contribute to cancers being obscured, and this occurs more in denser breasts. The digital breast tomosynthesis can improve the detection, and this is how it does it. The X-ray tube moves across the breast and takes a series of low-dose images which are taken from different angles, and then the images are then constructed into 1 millimetre slices, much like a CT scan, and then the lesions are much easier to see within each slice. So let me give you an example. In this single cranial caudal view, the breasts are heterogeneously dense and it's hard to see the mass. But when you look at the individual slices, you can see that between images 40 and 46, as marked by the yellow square, there is a spiculated mass, which you really can't see on the standard mammographic image. However, so digital breast tomosynthesis does increase the sensitivity, and in a screening program that will lower the recall rate so women don't get recalled back for further assessment as much. But it does involve an additional dose. For us radiologists, it takes longer to read, and there's a lot more data, and that slows things down for storage and viewing. It is higher cost, and it is available in private in Auckland, but it's not covered by Southern Cross. But it's not currently available in public hospitals for breast screen. Now, we do actually have it at North Shore Hospital, and we will be using it soon. What if you add screening breast ultrasound? Studies have shown that you can increase your pickup of cancers by 2 to 4 per 100,000 women screened. And for the women of intermediate risk who've had previous breast cancer, the average is about 2.9 additional cancers per 1,000 women. The average cancer size detected is about 10 millimetres, and mostly a node negative. And if you compare that to cancers found on physical examination, the average would be 22 millimetres. The sensitivity of mammography combined with ultrasound is a lot higher, and the sensitivity of screening breast ultrasound is better than digital breast tomography in dense breasts, because you really need fat outlining the tissue, the lesion or the mass to be seen on DBT. The positive predictive value is low. Now, what I mean by this is that if you were told you had a lesion seen on ultrasound, the chance of having a cancer is low. It can be as low as 6.5%. So what that means is that if we find 100 lesions and we biopsy them all, 94% would actually be benign. Here's another case where this patient has had a previous right mastectomy. We have the current mammogram on the right and the previous on the left, and I couldn't see any abnormality on that. And the cranial caudal views, similarly the current and the prior, and I couldn't see anything on that either. So we did an ultrasound, and to my surprise, she had a little mass, about 4 millimetres, in the left breast at 10 o'clock position. I did a biopsy of that, and that came back as an infiltrating ductal carcinoma. So I went back and had a look at the mirror, and I still cannot see it. She went on to have a hook wire partial mastectomy, and the final pathology actually showed 20 millimetres of grade 1 infiltrating ductal carcinoma. Here's another case where the breasts are not very dense, but you can see an enlarged lymph node in the left axilla. And this is the tomosynthesis. So we go scrolling through the slices, and nothing really jumps out. So just doing that again. So nothing seen on the mammogram or the breast tomosynthesis. On the ultrasound, ultrasound of the axilla showed a mass in the axilla, and the box with the colour just shows that it's got lots of blood vessels in it. But ultrasound of the breast found no abnormality. A fine needle aspiration of the lymph node confirmed it was metastatic adenocarcinoma of breast origin. So she came to our clinic, and the surgical registrar did an examination, and he felt a mass. And so we went back and repeated the ultrasound, and there was a very subtle abnormality. It's only 4 or 5 millimetres, but that's the only thing that was in that area of the lump. So did a biopsy of that, and that was infiltrating ductal carcinoma. So they can be pretty subtle. So she went on to have a hook wire localised partial mastectomy. There's this X-ray of the specimen, and there was 70 millimetres of grade 3 infiltrating ductal carcinoma, which really wasn't seen on the original mammogram or the original ultrasound. What's the role of breast MRI? Well, it's used for screening in the high-risk group for the BRCA gene mutations. First-degree relatives with the BRCA mutations, any woman who's had history of chest irradiation between the ages of 10 and 30, or a greater than 20% lifetime risk of breast cancer. The reported sensitivity is much higher than mammography. In high-risk women, 70% versus 32%. The combination of mammography and MRI has the highest sensitivity at 84%. So you can alternate, do one and then do the other at 6-month intervals, so you can do them both together. However, there's insufficient data to recommend for or against MRI for women having intermediate risk of breast cancer. So that includes having a personal history of breast cancer. Here's a case where I couldn't see anything on the MLO views. On the CC view, there is a little asymmetric density in the lateral aspect of the left breast. In ultrasound, there was a little a little mass, very irregular. And biopsy, that was an invasive lobular carcinoma. So what we do with these is that we always do an MRI, because there is, so that shows the original cancer in the left breast. That little area of white, which is the enhancement after contrast. And there was also an enhancing lesion, a much smaller one, in the right breast. And the report suggested it may be a fibroadenoma, because sometimes they can enhance, normal lymph nodes can enhance. So the MRI is not particularly specific. There was an abnormal area. So we did a second look ultrasound, and we found this lesion, again, which is rather non-specific. I mean, it could be a fibroadenoma, it could be cancer. But the biopsy did show another invasive lobular carcinoma. Is there a relationship between the number of mammograms read by radiologists and the cancer detection rate? In a study of breast-free New South Wales in 2000 to 2001, of which 133 radiologists were involved, they read 900,000 mammograms and detected 3,800 cancers, and the cancer detection rate was 42 per 10,000. The cancer detection rate increases with the number of mammograms read, and it reaches a plateau at around 1,300 mammograms per year. And there's no significant improvement in cancer detection rate above reading 875 mammograms per year. Other studies without such large numbers haven't shown any difference, but they did say that other factors were important, especially things like double reading, which is what we do in New Zealand. Funnily enough, a lot of these studies come from the States and they don't double read. What is the minimum number of mammograms that radiologists are required to read per year? Well, if you work in breast screen, the number is 2,000. If you don't work in breast screen and you work anywhere else, there is no stipulation. In breast screen New South Wales, it's 2,000. In the United Kingdom, it's 5,000. In Canada, it's 2,000. And to my surprise, in the United States, it's 480. So again, there's current debate as to whether there should be a law change to double that number. Who's the best operator to perform the breast ultrasound? Because there are many people who can do that. Sonographers. Now, in some places in town, you can get an ultrasound done in places where they have no mammograms. So other places, they do mammograms and they can talk to the radiologist about where to scan. Radiologists who subspecialise in breast imaging will do their own ultrasound. Other radiologists can also do scanning, but they may not be subspecialised, or they may be subspecialised in other specialties. Breast physicians will scan. Again, they may not have access to the mammograms because they're reported by the radiologists. And breast surgeons can also scan. Then there's no studies which show who is better. In conclusion, mammography is the only modality proven to reduce mortality from breast cancer. Breast ultrasound is an adjunct to mammography, not a replacement. Breast MRI in conjunction with mammography is for high-risk women. No imaging modality is perfect, and clinical examination is still important. So my recommendations are to have annual mammograms until 75, but you can screen after that if you're still well. Add digital breast tomosynthesis if there's no additional dose, and some of the manufacturers are now able to synthesize the standard views from the stack of images. So you'll have two on each side instead of 3 or 4. Have your mammograms read by a radiologist who reads a high number. Now, obviously, if you're in the public system, you have no control over that. But if you're in private, you've got the choice of going to a general radiology place, or you can go to a specialist breast clinic. Add screening breast ultrasound of the breast if they're not fatty, and you may have an additional pickup of breast cancer. And have your ultrasound performed by an experienced operator, and continue to have regular clinical examination. Thank you.